I want you to picture something for a second. It's a classic movie scene. You're standing in the control room of a nuclear power plant.
Right.
It's sterile, it's quiet, but there's this underlying hum of, well, tension. You have these walls of panels, flashing lights, digital readouts, and everyone in that room, they know one thing. The stakes are absolute.
Utterly absolute.
If a reactor fails, if the core melts down, it's not just a bad day at the office, it's a catastrophe. It's Chernobyl. It's Fukushima.
It's a global news event that changes history. The definition of a high-stakes environment.
Exactly. And because those stakes are so incredibly high, we've spent decades building entire branches of engineering dedicated to one single goal, ensuring that failure is, for all intents and purposes, impossible.
Practically impossible, yes. We don't just hope it doesn't break. We have to mathematically prove that it won't.
That's the standard, right?
That is the standard. We build in redundancies. We have fail-safes for the fail-safes. We have these incredibly rigorous protocols designed around a very specific assumption, which is that humans are terrible at being consistent.
So you assume failure from the start.
You assume the operator will make a mistake, and you engineer the system to catch that mistake before it ever becomes a disaster.
Okay, so hold that image in your head, nuclear control room. Now, I want you to teleport to an operating room. The lights are bright, the patient is on the table. The stakes, I'd argue they are just as high.
Oh, absolutely. Life and death.
Life and death. Irreversible harm. If things go wrong, a family is just destroyed.
The stakes are identical.
But here's my question, and this is really what we're wrestling with today. Does that operating room function like a nuclear plant? If a surgeon has a bad day, or maybe they didn't sleep well, or they just have a slightly shaky hand, do we have the same level of engineered safety to catch that?
It's a terrifying question when you really sit with it.
Or are we just crossing our fingers and hoping they're as good as their reputation?
And the short answer is no. Medicine does not operate like a nuclear plant. In fact, it operates on a completely different philosophy.
I have to be honest with you. When I first looked at the source material for today, I was skeptical. I mean, comparing a surgeon to a nuclear safety engineer feels like a massive stretch.
Feels like apples and oranges.
Totally. One deals with uranium and concrete, the other deals with biology, which is messy, it's unpredictable. Can you really apply engineering logic to the human body?
That's the tension, isn't it? It feels cold, it feels mechanical. But we're looking at a position paper today that argues that our warm approach, our focus on the human touch, is actually getting people hurt.
Okay, so let's get into it. What's the paper?
The paper is titled Medicine as a Safety Critical System, a Probabilistic Risk Assessment of 50 U.S. Diseases.
It was written by Lev Neymotin, PhD, from N5 Digital Inc., and it was published just today, February 3rd, 2026. Now, what's interesting here is that Neymotin isn't a medical doctor. He's not a surgeon.
No, and that's actually his superpower here. That's the key.
He's coming at this with an engineering mindset. Specifically, he has a background in something called Probabilistic Risk Assessment, or PRA.
And this isn't just any engineering field. This is the exact methodology used in nuclear reactor safety analysis.
Wow.
So he is looking at the U.S. healthcare system, not as a doctor, but as a safety engineer, looking at a very, very dangerous machine.
And his core proposal is what exactly?
His core proposal is that medicine needs to stop relying so heavily on clinical judgment, which varies wildly from doctor to doctor, and start using the same rigorous risk frameworks that keep reactors from melting down.
He's basically saying that the human touch in surgery, the thing we usually value, the so-called art of medicine, might actually be a bug, not a feature.
Precisely. It challenges the fundamental identity of what it means to be a doctor. It really shifts the view from medicine as this craft practiced by artisans to medicine as a safety-critical system that needs to be engineered.
So our mission for this deep dive is to see if this holds water. We're going to explore how applying this nuclear logic to the messy world of human biology reveals some pretty hidden patterns of risk.
We're going to see why the common cold might be a bigger societal problem than we think.
And why hand surgery is, weirdly enough, the perfect test case for the future of medicine. But before we get to the robotic future, I really need to understand the problem. Why do we need a new framework?
I feel like I'm constantly bombarded with medical statistics.
Oh, constantly.
Survival rates, efficacy percentages, side effect risks. Don't we already have this covered?
We have data. Certainly we're drowning in data. But Neymotin's argument is that we don't necessarily have the right kind of risk assessment.
What do you mean?
Currently in medicine, we rely on metrics like QALYs and dailies.
QLEs and dailies, right. I see these in health policy articles all the time, but break them down for me. What are they actually measuring?
So QLI stands for Quality Adjusted Life Year. Daily is Disability Adjusted Life Year. They are, at their core, economic and prognostic tools.
Yes. They're used to determine if a treatment is worth it.
Yeah.
For example, if a new cancer drug costs, say, $100,000, does it give the patient enough quality years to justify that cost to an insurance company or the government?
So it's a cost-benefit analysis. It's about value for money.
Correct. Or we have clinical risk scores. They tell you, based on your age and weight, you have a 10% chance of a heart attack.
Yeah.
Which is useful for you as a patient, for your own prognosis.
Right.
But Nemotin points out a critical limitation here. These metrics, they look at the outcome after the fact, or they look at biological probability. They do not look at system-level preventable risk.
Okay, I want to push on that. What is the difference between outcome and system-level risk? If the outcome is the patient died, isn't that the risk?
Not to an engineer, no.
How so?
Think about it this way. In the aerospace industry, or in nuclear power, if an operator makes an error, the engineers don't just throw up their hands and say, well, that pilot needs more training.
They don't.
No. They view operator error as a design flaw in the system itself.
Wait, really? So if a pilot falls asleep or hits the wrong switch, that's the engineer's fault?
In the philosophy of safety-critical systems, yes, absolutely. If the system allowed the pilot to hit the wrong switch and crash the plane, the system is fundamentally broken. The design failed.
That is a huge shift in responsibility, a massive one.
It is. If a button is too easy to press by accident, you don't blame the person who pressed it. You put a guard over the button. You change the shape of the handle so it feels different. You build in a lockout mechanism. You make it impossible to do the wrong thing.
Right. You design the environment to force safety. You idiot-proof it.
Precisely. But in medicine, we don't do that. Variation between doctors, the fact that Dr. Smith might have steadier hands than Dr. Jones, or that Dr. Jones has a better success rate with knee replacements, is just accepted.
We just shrug and say.
Well, that's the art of medicine.
We even seek it out. We ask our friends, who's the best surgeon? Who has the golden hands? We treat it like we're commissioning a painting.
And Nemotin argues that this variance, this very difference between doctors, is actually a massive red flag. It's a signal that the system relies way too much on human precision and not enough on engineered safeguards.
If safety depends on which doctor you get, the system is unstable.
By definition.
So to fix this, he wants to bring in PRA, Probabilistic Risk Assessment. This comes from the nuclear world. Can you give us a little history here? Is this a new idea?
Not at all. The concept of PRA really solidified with the reactor safety study in 1975, also known as WASH 1400.
WASH 1400, okay.
Before this, safety was very deterministic. Engineers would say, if this pipe breaks, then this emergency water pump turns on. We are safe. A simple is-then statement.
That sounds reasonable, logical.
It's reasonable until the emergency water valve jams, or the power goes out, or the operator, under immense stress, turns the water off by mistake, which actually happened at 3 Mile Island.
Oh, wow.
WH 1400 introduced the idea of mapping the entire risk landscape. You don't try to predict exactly when an accident will happen. Instead, you structure the uncertainty.
What does that mean, structure the uncertainty?
It means you look at every possible chain of events, every valve, every switch, every human action, and you assign a probability to it. Yeah. You create these enormous fault trees that map out all the ways things could go wrong, from the tiniest component failure to a major human error.
It sounds incredibly complex, almost impossibly so.
It is, but the core formula is actually quite simple, and this is what Nemotin adapts for medicine. The formula is risk, which we'll call $3, equals frequency, multiplied by consequence severity.
Risk equals frequency times severity, ASF times CSO.
That's it. And the goal is to make all these implicit trade-offs explicit.
How so?
Well, in a nuclear plant, you might have a tiny valve leak that happens all the time, high frequency, but the severity is incredibly low. It's just a puddle on the floor. You mop it up.
Annoying, but not dangerous.
Exactly. On the other hand, you might have a full core meltdown. The frequency is vanishingly low. It might happen once in 10,000 years, but the severity is catastrophic. It ends the industry. PRA allows you to put those two very different things, the puddle and the meltdown, on the same mathematical scale to figure out what you really need to worry about.
So Nemotin is taking this nuclear logic and pointing it at the human body. He's asking, what happens if we rank diseases not by how scary they are or how much money they cost, but by this cold, hard engineering definition of risk?
Exactly. And to do that, he had to build a new measuring stick. He couldn't just use death rates or something simple like that.
Right, because risk isn't just death. It's suffering, it's disability, it's lost time, lost function.
All of it.
So let's look at the variables he uses for the U.S. healthcare system. For frequency, he uses U.S. cases per capita per year.
Which is crucial. It normalizes everything. It puts the common cold and stage 4 pancreatic cancer on the same mathematical playing field based simply on how often they occur in the population.
And then for consequence severity, CDT Sui developed a graded scale from 1 to 100. Now, this is where I get a little skeptical again.
And that's fair.
Assigning a number to human suffering feels subjective. Who decides that a broken leg is a 30 and diabetes is a 60? How do you even begin to do that?
That's always the challenge with these models, right? You have to draw a line somewhere.
Yeah.
But Moten needed a standard. He didn't just look at mortality. In nuclear engineering, you don't just look at the plant blowing up. You look at environmental damage, economic loss, system disruption.
A total impact.
The total impact. So his severity bands reflect that broad impact on a person's life and on society.
Let's run through these bands because they really set the stage for the rankings. I want to see if they pass the smell test for me.
Okay. Band 1 is the highest severity, scored 76 to 100. This includes death, profound disability, or catastrophic societal cost.
So we're talking about cancer, severe heart failure, a massive stroke.
The heavy hitters, the things that end your life or ruin it completely.
Okay, that makes sense. I can accept that as the top tier. What's next?
Then you have Band 2, scoring 51 to 75. This is chronic disease with functional impairment. You're not necessarily going to die tomorrow, but your life is significantly and permanently altered.
You rely on medication, you have chronic pain.
You can't work the same way. This is where things like depression, diabetes, and severe arthritis fall.
See, that's interesting. Putting depression in band 2, I think a lot of people would argue that severe treatment-resistant depression can be a band 1 condition in terms of how it completely destroys a life.
And that is a valid critique, and it highlights the difficulty of this. But in this model, unless it leads directly to suicide, which would then be a mortality event and shift it, it's categorized as functional impairment. It's a very high burden, but distinct from immediate biological death.
It's a model. It has to have rules. I get it. Okay, band 3?
Band 3 scores 26 to 50.
Yeah.
This is temporary but significant. It disrupts your life. Things like anxiety disorders and the aggregate or orthopedic injuries like broken bones.
So you need medical care. It stops your life for a while, but you usually recover.
Right. And finally, Band 4.
The easy stuff.
Band 4, scoring 1 to 25. This is inconvenience. The common cold, minor infections, things that are annoying, but don't fundamentally alter your life's course.
Okay, so we have the math. Frequency times severity. And he ran this analysis on 50 common U.S. diseases.
I have to say, looking at the results in Table B1 of the paper, there were some serious surprises.
Oh, absolutely.
I expected the killers to be at the top, and they were, but not in the way I thought, and not alone.
The results reveal what Moten calls structural patterns, and these patterns are often completely invisible if you're just looking at, say, the CDC's mortality stats.
Right. So the first pattern is what I'm calling the frequency dominators, and this one, it actually made me laugh, but then it made me think. The common cold and gastroenteritis, stomach flu rank, extremely high in total population risk.
It seems ridiculous, doesn't it? We don't think of a cold as a risk that's in the same ballpark as heart disease.
Not at all. It's an annoyance. But remember the formula. Risk equals frequency times severity. The severity of a cold is, what, a 15 out of 100? It's low. But the frequency is massive. Moten cites about 2.9 cases per capita per year.
That is nearly 3 colds for every single person in the country every year. That's hundreds of millions of sick days, lost productivity.
Exactly. So when you multiply that enormous frequency by the low severity, the aggregate burden on society, the total risk is huge. It's death by 1,000 cuts.
So from a system engineering perspective, a cure for the common cold would be a monumental achievement.
Staggering. The economic and productivity boost to the country would be absolutely staggering, possibly more impactful than curing a rare but fatal disease.
That is a cold, utilitarian way to look at it, but I guess that's the engineering mindset.
It is. It's about system optimization, not just individual drama.
Then you have the second pattern, which is more familiar, the severity dominators.
Right. This is ischemic heart disease and cancer.
No surprise there.
No surprise. They rank high because their severity score is 95 to 100. The consequence is so high that even though they're less frequent than a cold, they stay right at the top of the list. This confirms that our current focus on them is correct. They are major system risks.
But then Then we get the third pattern, and I think this is where the deep dive really begins. This is where the paper stops being just a list and starts being a manifesto. The procedural clusters.
This is the critical finding. This is the whole ballgame. There's a cluster of diseases, things like cataracts, osteoarthritis requiring joint replacement, certain cardiovascular interventions.
Things that a lot of people get as they get older.
Exactly. They have moderate frequency and moderate severity. They aren't the biggest killers. They aren't the most common annoyances. They're in the middle.
So why are they so important?
Because they share a unique characteristic. They have high operator dependence.
Operator dependence. This brings us right back to the nuclear operator versus the surgeon.
Right. These are conditions where the outcome depends heavily, sometimes almost entirely, on who is doing the procedure and how well they execute it.
So Nemotin coins a term for these. He calls them procedural diseases. And he makes a very sharp distinction between procedural risk and biological risk. I want to spend some time here because I think this changes how a patient should look at their own diagnosis.
It's a vital distinction. Biological risk is the disease just doing what the disease does.
The natural course of the illness.
Exactly. If you have a genetic condition that causes your cells to degenerate and there is no cure, the risk is purely biological. The doctor can observe it, maybe manage the symptoms, but the trajectory is set by the biology.
The doctor is just a passenger, essentially. They're managing the ride, but they can't stop the train.
In terms of the ultimate outcome, yes. But procedural risk is different. In a procedural disease, the trajectory of the patient is actively determined by an intervention. The doctor gets in the driver's seat.
He breaks the outcome down into 5 layers. And looking at these layers really changed how I view a surgery. I always thought surgery was just cut out the bad thing.
It's so much more nuanced. Let's walk through them. Layer 1 is the biological baseline.
That's the given.
That's unavoidable. The patient is sick. You can't blame the doctor for the patient having clogged arteries in the first place.
Right. Layer 2 is decision accuracy. Did the doctor choose the right treatment?
This is the diagnostic and planning phase. Did they decide to operate when they should have used meds? Did they pick the right approach? That's a cognitive error.
But layer 3 is the big one for this paper, execution precision.
This is the physical act, the hands, the craft.
Did the scalpel go exactly where it was supposed to? Was the implant aligned within a millimeter of perfection?
And this is directly linked to layer 4, collateral effects. Did we damage nearby tissue in the process? Did we nick a nerve? Did we puncture a vessel?
And layer 5 is recurrence. Did we get it all, or did we leave something behind because the execution wasn't perfect?
Exactly. So in a procedural disease, layers 3, 4, and 5, execution, collateral damage, and recurrence, are the main drivers of whether the patient gets better or worse. The biological baseline matters less than the surgeon's skill.
And that is the operator variance problem.
It is. In engineering PRA, if a safety system relies on a human pressing a button at the exact right millisecond with perfect pressure, that is considered a bad design. You would never certify a nuclear reactor that relied on that level of human perfection.
Because humans fail. We're not machines.
Humans get tired. Humans get distracted. Humans have tremors. Humans have bad days.
But in medicine, we rely on training to perfect the human. We say, Dr. Smith is a genius. He has golden hands. We train them for 10, 15 years to try and turn them into precision machines.
And Nemotin argues this is a fundamentally unstable safety strategy because even the best doctor can have a fight with their spouse before work. Even the best doctor gets older and their eyesight changes.
So that variance is a warning sign.
If high operator variance exists, meaning you get different outcomes from different doctors for the very same procedure, that is a signal. It's a bright, flashing red light that the system relies too much on human precision and not enough on engineered safeguards.
It's funny because we tend to idolize the surgeon as this craftsman, this artist. You want the artist working on you, but Nemotin is saying, no, you want the engineer, you want the assembly line worker.
You want the system where the art isn't necessary for a safe outcome. If I get on an airplane, I don't want the pilot to have to be a virtuoso to land the plane safely.
God, no.
I don't want to hear, oh, Captain Jenkins is the only one who can land at O'Hare without crashing. That would be terrifying.
That would be horrifying. You want to know that any certified pilot can land the plane because the system makes it standard and safe.
Exactly. I want the systems to be so good, so robust, that a competent pilot can land that plane safely every single time, regardless of whether they had a good night's sleep.
So, if we accept this premise, that relying on golden hands is a bad design strategy, what's the solution? We can't just fire all the doctors.
No, of course not. The solution he proposes is called precision enforcement.
Precision enforcement. It sounds a bit like a sci-fi police force. The precision police are here for your scalpel, doctor.
It does sound aggressive, doesn't it? But it's a very practical engineering concept. It's not about training doctors harder.
Why not? Isn't more training always better?
You reach a point of diminishing returns with human training. You can't train a human to have perfectly steady hands for 12 hours straight. Physiology gets in the way. Precision enforcement is about introducing engineering constraints.
Give me some examples. What does an engineering constraint look like in a surgery?
It could be imaging guidance, seeing exactly where your tool is in real time on a screen rather than guessing by feel. It could be mechanical death stops, a tool that physically cannot cut deeper than X millimeters.
Like a guard on a circular saw. Simple.
Exactly like that. Or it could be robotics that tremor filter the surgeon's movements. You move your hand an inch, the robot moves a millimeter, and it removes any shaking.
Or feedback loops.
Yes, feedback loops that beep or vibrate if you get too close to a nerve that you've mapped out beforehand.
So the goal is to suppress variance, to make the bell curve of outcomes much, much narrower. You want the worst surgeon's outcome to be almost as good as the best surgeon's.
You want to raise the floor of performance so high that the ceiling barely matters. You want to take the heroism out of the procedure.
Now, Nemotin doesn't just talk about this philosophically. He actually introduces a specific math formula to calculate how much risk we can actually get rid of. He calls it the delta risk formula.
Delta risk,
Ugh.
the change in risk. This is the heart of the proposal. It attempts to quantify the potential benefit of this precision enforcement.
Okay, let's look at the formula. Delta R, F times CS times Q times K times R delta. Now, we already know for frequency and C dollars consequence severity from before.
Right, that's the total risk for the disease.
But those last three letters, $2 and $2, are new, and I think tollers is going to upset some people. But let's start with toller. What's that?
The dollars is procedural exposure. This is a simple but important factor. It asks, how many patients with this disease actually get the procedure?
Right. Because if you have a disease but nobody ever operates on it, then inventing better surgical tools doesn't help at all.
Exactly. If everyone treats it with pills, then surgical robots are useless. It measures the opportunity for the tool to even be used.
Okay, makes sense. Next is toller operator dependence. This is the controversial one.
This is the one where we have to assign a number to the doctor's impact.
How do you even do that?
Conceptually, it asks, what percentage of the harm of the bad outcomes comes from the doctor's hands versus the disease itself? If a disease is purely biological, like a systemic infection, tolerance is 0. The doctor's hand steadiness doesn't matter.
But if the outcome depends heavily on cutting the right thing and not the wrong thing...
Then tolerance is high. Maybe 0.8 or 0.9. It's a big multiplier.
And finally, we have Tor dollars.
Tor dollars is reducibility. This asks a practical question. How much can technology actually fix this? Is it physically possible to engineer a tool that solves the problem? Or is it so complex that no tool can help?
So delta risk basically tells us, for a given disease, if we invent and use better tools, how much total suffering can we erase from the population?
Yes, and it shifts the entire conversation. We usually ask, is this treatment effective? Meaning, does the drug work in a perfect trial? Nemotin wants us to ask, is the delivery of this treatment reliable in the real world?
That is a huge shift. Reliability versus efficacy.
Think about it. We have surgeries that are highly effective if performed perfectly. But if they're only performed perfectly 80% of the time across all hospitals and all surgeons, the system is not reliable.
A car that drives perfectly 80% of the time and crashes 20% of the time is not a good car. It's a death trap. To make this concrete, because formulas can get abstract, the paper dives into a specific case study. And frankly, I had never heard of this condition before reading this, but now that I know about it, I can't unsee it. Dupuytren's contracture.
It is the perfect anchor for this entire analysis. It's almost as if it were designed to prove his point.
So, paint the picture for us. What is Dupuytren's contracture?
Imagine your hand. Under the skin of your palm, there's a layer of connective tissue called fascia. In Dupuytren's, this tissue starts to thicken for reasons we don't fully understand. It forms these hard knots, and then it forms thick, fibrous cords that run from your palm up into your fingers.
And these cords tighten.
They tighten relentlessly.
Yeah.
Over time, they literally pull your fingers, usually the ring and pinky finger, down towards your palm until they're stuck.
So you can't open your hand.
You end up with a hand that is permanently clenched. You can't put your hand flat on a table. You can't put on gloves. You can't shake hands properly. You can't wash your face without poking yourself in the eye.
It sounds incredibly frustrating and disabling.
It is. It's not fatal, so it's not a band 1 severity. The paper puts it at about a 55 on the severity scale. It ruins your quality of life,
Yeah.
and it's moderately frequent. But here is why it fits the PRA model so perfectly. It is extremely procedural.
Because to fix it, you have to go in and cut that cord. Right, that's the only way.
You have to physically sever or dissolve that cord to release the finger. But here is the anatomy nightmare. I want you to visualize the inside of the human hand. It's incredibly crowded. You have this white, thick, diseased cord that needs to be cut.
Okay, I'm picturing it.
Wrapped around that cord, sometimes spiraling around it like a vine, are the digital nerves that give your finger sensation. And right next to them are the digital arteries that supply blood.
And what color are the nerves in the cord? Don't tell me.
They are both whitish. The cord is white. The nerve is a whitish yellow. In the mess of surgery, they can look almost identical.
Oh, no.
So you're cutting a white cord that is stuck to a white nerve, and if you cut that nerve,
Ruin the finger.
permanent numbness, chronic burning pain. You might fix the bend in the finger, but now the patient has a dead finger that feels like a block of wood. That is a disaster of an outcome.
So the operator dependence, that $2 variable, is sky high. The difference between a cured hand and a ruined hand is literally millimeters.
It is entirely dependent on the surgeon's ability to visually distinguish between two very similar white structures and move a scalpel with perfect control in a very small space.
And there's another factor, recurrence. The paper mentions that the disease often comes back.
It does. And a big reason it comes back is incomplete execution. A surgeon is so terrified of hitting the nerve that they become too timid. They leave a little bit of the diseased cord behind.
And that little bit just grows back.
It grows back, and the patient is right back where they started, only now they have scar tissue from the first surgery, making the second one even harder and more dangerous.
So the surgeon is in this terrible bind. They're balancing, don't cut the nerve, with cut enough of the cord. And they're doing this largely by hand and eye.
And by feel. Many experienced practitioners will tell you they can feel the difference in density between the cord and the nerve with the tip of their scalpel.
Ah, the art of medicine again. Trust my golden hands.
Exactly. And to an engineer like Lev Nemotin, that statement, trust my hands, is terrifying. It's subjective, it's unmeasurable, and it's completely unreliable across a population of thousands of different surgeons on thousands of different days.
So how do we apply the nuclear safety logic here? What does precision enforcement look like for Duputrins?
Nemotin references a proposal for a precision-guided system. So imagine a tool that doesn't just rely on the surgeon's eye. Maybe it uses high-frequency ultrasound or some other imaging modality to visualize the nerve in real time, overlaying it on a screen as a no-go zone.
Like a stud finder, but for nerves. You're painting the danger zones red.
In a way, yes. Or imagine a specific cutting tool with mechanical death stop. It physically cannot cut deeper than the thickness of the cord. It prevents the blade from ever reaching the artery or nerve that lies beneath.
That would be precision enforcement. It takes the variable, the shaking hand, the bad lighting, the moment of distraction out of the equation.
Yes. Now, apply the delta risk formula. We have frequency, moderate, severity, moderate. Procedural exposure is high because surgery is the main fix. Operator dependence is very high. And reducibility is also high because these are mechanical problems that tools could theoretically solve.
So mathematically, this is a prime candidate for engineering. It scores high on the we can fix this scale.
It absolutely does. But, and the paper notes this, and I think we have to address it, there is a debate. There is resistance to this way of thinking.
I can imagine. If I'm a hand surgeon who has done 500 of these, and I think I'm pretty good at it, and you come into my OR with your depth stop robot,
Yeah.
I might be offended.
You'd say, I don't need that crutch. I know what I'm doing.
My hands are steady enough. I've been doing this for 20 years. I don't need an engineer from a nuclear plant to tell me how to cut. It feels like an attack on their skill and experience.
Of course it does. But PRA allows us to mathematically evaluate that claim rather than relying on ego or tradition. We can look at the data. We can ask, what is the actual variance? How often do complications happen across the whole population of surgeries?
Not just in the hands of the top 1% of surgeons at the Mayo Clinic, but in the rural community hospital, in the busy general hospital where the surgeon is on their 5th case of the day.
Exactly. It takes the, I feel I'm good at this, out of it and puts the data shows this is the system's actual performance into it.
And what does the data usually show?
Often the data shows that while the top surgeons are incredibly safe, the average is much lower. And the performance of the bottom 10% can be quite dangerous. Precision enforcement isn't necessarily for the rock star surgeon. It's to make sure that even the average surgeon produces a rock star level safe outcome.
It protects the patient from the luck of the draw of which surgeon they get.
Precisely. And that forces us to ask a really tough question. Is the risk we are currently accepting actually necessary? Or is it preventable? If we have the technology to stop nerve damage, and we don't use it because some surgeons prefer their art, that becomes a heavy ethical question.
This brings us to the broader implications, because if we start applying this logic to everything, not just hand surgery, it really changes how we think about the entire healthcare system. It changes where the money goes.
It changes everything from NIH funding priorities to medical ethics.
Let's start with funding. Regulatory bodies like the FDA or research funders like the NIH, how do they prioritize right now?
The current model is largely driven by what I'd call the scary factor, or the new factor. We fund the deadliest diseases, the band 1 conditions, which make perfect sense. We want to cure cancer.
Of course.
Or we fund the newest, most cutting-edge biological drugs and gene therapies, the moonshots.
And we should. I mean, that's how we make breakthroughs.
I'm not saying we stop curing cancer, but the PRA model suggests a parallel track for funding. Maybe we should also be funding the areas where the delta risk is highest.
Meaning maybe we should spend billions of dollars making routine surgeries just 10% safer.
Exactly. Let's do the math on that. If you have a procedure that's done millions of times a year, like cataract surgery or C-sections or joint replacements, and you can engineer a tool that reduces the complication rate by even 1% or 0.5%.
The aggregate amount of human suffering you eliminate is massive. Absolutely massive.
It might be a bigger total benefit to society than curing a rare fatal disease that only affects 5,000 people a year. From a pure utilitarian engineering perspective, fixing the small risks that affect everyone is a huge win.
That is a hard sell politically, though.
Oh, incredibly hard.
We spent $1 billion to make sure fewer people have numb fingers after hand surgery. Doesn't sound as heroic as we cured a rare childhood cancer.
It doesn't get you on the cover of Time magazine. But from a pure reduction of population suffering standpoint, which is what PRA is designed to measure, it is incredibly efficient. It prioritizes the elimination of preventable risk.
And that leads right into the ethics. The paper asks a tough question. Is it ethical to tolerate preventable risk?
This is where it gets really philosophical and uncomfortable. If we can engineer the variance out of a procedure, if we have the technology to build a tool that stops a surgeon from hitting a nerve, do we have a moral obligation to mandate its use?
Moten argues, yes, we do.
He argues that tolerating variance when design solutions exist is very hard to defend ethically. Imagine two patients with the same condition. Patient A goes to Dr. Tech, who uses the new precision tool. Patient B goes to Dr. Traditional, who prefers using their hands.
And Dr. Traditional has a bad day, an off day.
And patient B gets a permanent nerve injury. Now, patient B didn't choose to be injured. They just happened to walk into the wrong room. Moten's argument is that the system failed patient B. The system allowed a lower standard of safety to exist because of tradition or ego or cost.
That is heady. It suggests that good enough isn't actually good enough if better has been engineered but is being ignored.
It fundamentally challenges the autonomy of the doctor. Historically, the doctor is the captain of the ship. Their judgment is final. But in a safety-critical system, the system is the captain. The doctor is a highly trained, essential operator within that system.
Which brings us to the future of the medical operator. If this thinking takes hold, what does the role of the doctor become? Are we turning them into button pushers? Is that the end game?
I think the role changes, but I don't think it diminishes. And I want to be really clear, Moten is not talking about robot doctors replacing humans entirely.
We're not talking about an AI doing the whole surgery while the doctor plays golf.
No. Biology is way too complex and unpredictable for that. Unforeseen things happen in the OR all the time. You absolutely need a human brain in the room. But it shifts the doctor from being a craftsman, an artisan relying on personal physical skill, to being a system manager.
A system manager. That sounds so corporate, less noble.
Think of the airline pilot again. A modern pilot is a system manager. They understand the automation, they monitor the systems, they intervene when necessary, and they use their incredible training and judgment for the complex decisions, weather, emergencies, diversions.
But they rely on the engineered systems to keep the plane in the air.
They don't try to fly the plane by flapping the wings with their arms. The system handles the basic execution with high reliability.
So it moves medicine from training dominance, where the answer is always just study harder, practice more to design dominance.
Exactly. And frankly, I think that should be a relief for doctors.
A relief? How so? I feel like most doctors would hate losing that control.
Think about the pressure. The burden of perfection that we place on them is crushing. We expect doctors to be perfect every single time for a 40-year career.
We expect them to be superhuman.
To never be tired, never be sad, never be shaky. That is not humanly possible. And when they inevitably fail, when an error happens, they are devastated.
The God complex pressure, the expectation that they can't fail.
Engineered safety takes some of that impossible weight off their shoulders. It says the system has your back. You don't have to be superhuman today. You just have to be competent and vigilant, and the design will ensure a safe outcome for your patient.
That's a really compassionate way to look at it. It protects the patient, but it also protects the provider from the devastation of making a preventable error.
Absolutely. The second victim in any medical error is often the doctor, who has to live with the guilt for the rest of their life. I cut the nerve. I ruined that musician's hand. If we can engineer out that possibility of error, we save the patient's hand and we save the doctor's conscience.
So, synthesizing all of this, Lev Nemotin's paper isn't saying doctors are bad. It isn't an attack on the medical profession at all.
Not in the slightest. It's saying that the system they work in is under-designed compared to a nuclear plant or an airliner cockpit. It's a critique of the environment, not the people. It's asking for engineering help.
We need to stop treating medical error as a moral failing. You weren't careful enough, and start treating it as an engineering challenge. The tools weren't safe enough.
Correct. We have this saying, to err is human, and we use it as a reason to forgive mistakes. Engineering accepts to err is human as a fundamental design principle, as a reason to build systems that don't let those inevitable errors cause harm.
That is a powerful distinction.
It's the difference between hoping for safety and actively engineering for safety.
So as we wrap up this deep dive into medicine as a machine, I want to leave our listeners with a thought. And it's a personal one. The next time you or a loved one goes in for a procedure, whether it's dental work, a knee replacement, or something more serious, look around the room. Look at the tools.
And ask yourself this question.
Is the safety of this outcome dependent on the surgeon having a good day, getting a good night's sleep, and having impossibly steady hands? Or is the safety baked into the design of the tools they are using?
Is it the artist or is it the machine?
Ideally, you want both. You want a great artist using the best machine. But if I have to choose, give me the machine that makes any good artist safer. Lev Nemotin's paper gives us a glimpse of what that future could look like.
It's a bit colder, maybe a bit less romantic than the TV doctor drama.
But it's a whole lot safer.
And in the end, safety is what matters.
Check your own risk landscape, stay curious, and we will catch you on the next deep dive.
Face it.